Hi friends, welcome. Today we'll be discussing about Mebomian gland disease, its diagnosis and management. MGD in the recent past has gained more popularity with the recent advances in the disease diagnosis and management. I have no financial disclosures. In this talk, I would cover the hair under the following headings. First, we'll see the background of MGD. Then we'll see different diagnostic techniques regarding gland morphology, tear film analysis, and also slit lamp examination. And we'll see the medical and non-medical management of MGD. The International Workshop on Mebomian Gland Dysfunction has defined MGD as a chronic diffuse abnormality of the meibomian glands that is characterized by terminal duct obstruction with or without qualitative and quantitative changes in the glandular secretion. So if you see the figure over here, meibomian gland disease and dry eye disease are closely interrelated to each other, and each step of the pathogenesis are also closely related. So whenever there is an MGD blockage or dropout, it will lead to proliferation of bacteria, and these bacteria will release lipases and esterases. This will in turn increase the melting temperature, and because of this, you'll have a lipid layer deficit, which increases the tear film evaporation, thus increasing the inflammation, and finally there will be keratinization of the MG orifices. So in a very close way, MGD and evaporative dry eye disease are associated with each other. So if you see here, in the upper lid, there are 25 to 40 meibomian glands, and in the lower lid, there are 20 to 30 glands. In the upper lid, the length is almost 5.5 millimeters, and in the lower lid, it is only 2 millimeters. Again, each of these glands, if you closely observe here, have 10 to 15 secretory acini, which secrete the meibum that forms an important component of the lipid layer of our tears. So this is how the normal glands look like, and this is how the lids in which there is a dropout of the glands or blockage of the glands. So coming to diagnosis, before we go into any fancy equipment or diagnostic techniques, the most important thing that you have to look for or examine is by a simple LLPP technique. That is look, lift, pull, and push. Look for base of the lashes for any blepharitis, look for lid position, blink position, tear meniscus height, conjunctiva, and cornea. So look for signs of inflammation on the lid margin. Next step, lift the upper lid that most of us commonly don't do. And when you lift the upper lid, you'll be able to visualize the superior cornea and also look at the conjunctival abnormalities that are there in the upper tarsal conjunctiva and rule out any SLK changes. After that, you pull the upper lid to look at laxity and floppiness. Finally, you push the lower lid and try to express the meibomian gland and see for meibum's quality and quantity. Once you do this basic technique, then you proceed to do a meibography. So is it necessary to have a dedicated meibographer? No. If you're just starting off with your dry eye clinic, I think one of the existing equipment that you already have in your clinic is more likely to have a mibography imaging thing that is already built in it. All it needs is an infrared light source and a camera that can capture it. So if at all you don't have this, I'll also give you a simple option of doing a infrared light source and how to capture it. Then I'll describe about the dedicated or advanced memographers. And if you want to know more in detail, we can have a slide on IVCM also. So if you see here, when you throw white light onto the lower lid, you can't really appreciate any of the Mebomian glands. But when you do it with surface illumination, here you can beautifully delineate these glands in the lower lid. So how do you do the surface illumination with infrared light? So if you see, most of the autorefractometers will have this infrared source. So these are the pictures taken on an autorefractometer. These are the pictures that are taken from a non-contact tonometer. And most commonly, if you're using an IOL master, even there you can look at these glands beautifully with the help of infrared ray. If you're having a fundus camera that has IR illumination, again, you can beautifully see the glands as shown here. And finally, if you have access to specular microscopy also, you can beautifully see these glands. If at all you don't have infrared illumination in any of your existing equipment, it is very simple to do the do-it-yourself mebographer. All you need is an 850 nanometer light source, which is available like a torchlight in the Amazon. It costs around 6,000 to 7,000 rupees. The light that comes out of it will not be visible to naked eye, but once you shine this light and try to capture it with a camera that does not have an infrared filter. See, this for example is the light captured with a photo slit lamp, and when you do the color adjustment, you nicely are able to delineate this Mebomian glands in the upper lid. So if you don't have an access to photo slit lamp also, some phones like the Samsung smartphones, there are some models which are available without the IR filter. So all you need to do is a torchlight with 850 nanometers light source and a camera without IR filter. Lo and behold, you'll be able to see this beautiful glands in the lids. So now let's go into more conventional or standalone mebographers. The picture you're seeing here is the mebography that is taken on the CSO series, where it is taken from the infrared imaging, and it also has a grading system inbuilt into it. And once you do the area of interest where you want to analyze, it will automatically give you the severity and grade of MGD. And here one more advanced equipment from Johnson & Johnson is Lippy Scan. So here again, it has dynamic illumination, trans illumination, and a combination of both. And here the clarity is even better when you compare it to a regular infrared imaging, because here what happens is any artifacts that are there because of reflections are taken out from the picture and you get a more clearer image. However, these equipment are expensive when compared to the previous equipment I have shown you. If we go a step further, we have something called as Hydra from SBM, in which you have an automatic detection of the Mebomian glands, where it detects these glands automatically. You need not delineate them manually. And the best part, it also creates a 3D remodeling of these glands. So you can see actually how these glands are inside the lids. Finally, once you get these images, most of the dedicated mebographers have this Miibo Scale that is inbuilt into their software. But if you are using any of the infrared light sources in other equipment, you can use this as a reference scale and then see how much amount of damage or loss of area of loss is there in the lids. Now let's go a step further. So if you are having access to in vivo confocal microscopy, which is very expensive, you can actually go and look at the lumen of these glands. If you see in this picture, this is a normal picture where the lumen is quite good. There are no obstructions here. But when you see in this picture B, it is called as type 1, in which there is lumen obstruction with minimal inflammation that is seen. Next is picture C, or type 2, where you see intraepithelial and intraglandular inflammation that is much more pronounced than this previous picture. And final stage is fibrosis and epithelial destruction, where you don't see any glands or lumen at all. So that is about the diagnosis of Mebomian glands, right from your basic equipment to the most advanced. Now, let us go to the next step of analyzing the tear film. Now that you have seen the glands, how do you see the tear film? In tear film, we are more worried about the lipid layer thickness that is specific to this Mebomian glands. And one more important indirect test is the non-invasive T-BUD, in which the tear breakup time reduces because of early evaporation of the lipid layer. So if you see here, there is something called as Lippy view. Lippy scan is for the glands. Lippy view is for the lipid layer thickness, LLT. So in a Lippy view, if you have a value of more than 100 nanometers, it is considered to be normal. And any value that is below that, like 58 nanometers, is abnormal. And this particular case tends to have a Mebomian gland disease. So if you see, you can easily correlate between the LLT and the mebomography scan. So here, if you see where the LLT is around 50, you can appreciate how the dropouts are there in the Mebomian glands in both the pictures. Next, coming to a non-invasive tear breakup time. This is a picture or a video clip taken from, again, from Sirius, from CSO. So once you take this image, so the green color thing, what you're seeing here is the regular tear film, and those spots that are seeing are the dry spots that are occurring sequentially. So that is how here, if you can see in this picture, so the dry spot has started peripherally here at around 2.9 seconds, then at 3.5 and 3.7, you have two more dry spots here, and then at 4 seconds here, and at around 5 to 6, you have more dry spots here. So here, when you see a dry spot that is less than 10 seconds, you should definitely suspect a dry eye because of a MGD or improper lipid layer. Now that we have finished the diagnosis, let us see the management part of MGD. The management part of MGD again goes back to the circle I showed you in the first slide. It depends upon the stage of the disease and stage of dry eye and how you have to interfere. So as long as the Mebomian glands are involved, lid hygiene is important. When there is a lipid layer deficit, you complement the artificial tears that are having lipids. Then when there is bacterial infection, you go for lid hygiene. When there is increased evaporation, you use osmoprotection. For lipases and esterases, you use orotetracyclines. For inflammations, you use steroids. And again, for increasing the melting temperature, you do lid hygiene and warm compresses. So these are all, again, as I have told you, interconnected to each other. So let us see the medical management that we commonly follow at our institutes. The antibiotics play a very important role here, both for its antibiotic properties and also its anti-MMP properties for the lipases and MMPs that are released by these organisms. We prefer to give oral doxycycline 100 mg BD 2 to 3 weeks, and in advanced cases, you can continue it for over 1 to 2 months. And for nighttime application, we give azithromycin 1% eye ointment, and we continue it for 2 to 3 weeks. And morning time, we give a azithromycin dexamethasone combination eye drops, BD or TID, for 2 weeks for the inflammation to get controlled. And later it is maintained only on plain azithromycin eye ointment. In the anti-inflammatory part, cyclosporin A can be used, either 0.05 or 0.1%. thrice a day for 3 to 6 months. Rarely we use steroids like dexamethasone and prednisolone. We start off with 4 to 6 times and slowly taper it. Usually, if the inflammation is not controlled, we start off with low dose steroids like lotiprednol 1 to 3 times and continue it for 3 to 6 months. Lifitegrast and interleukins are not available in India and we don't have experience with them. Essential fatty acids again is a controversial topic. Though the DREAM study doesn't recommend the use of essential fatty acids, 80% of Ascaris Corneal Clinical Committee recommend the use of essential fatty acids, and they feel it has a beneficial role as an adjunctive therapy. As essential fatty acids like omega-3 fatty acids may not cause any harm to the patient, there is no harm in giving these drugs for 3 to 6 months. And the last but not the least, it is very important to treat blepharitis and desmodex with rigorous lid scrubs and tea tree oil. So now let us see the non-medical management. So we regularly use the hot compresses and lid massages. So that may not be as effective as the techniques that we are showing here. So after hot compresses, now there are several Mebom expressors that are available in different companies. So at a time, you can start expressing out 3 to 4 glands. You start off from one lid margin and slowly go to the other side of the lid. This is a very inexpensive but very effective way. This you can do periodically for every 2 to 3 months. Give a hot compress, give a course of doxycycline, wait for 1 week, and then ask the patient to come back and do this manual expression. Next, we have Lippy Flow. Again, this is a very advanced therapeutics from Johnson & Johnson again. So here, actually in this picture, the device is not shown, but what happens here is, though all the other situations you apply heat from the anterior part, here the heat is applied also from the posterior part of the lid and compressions are manually given to express out the mebum from the acini, which are now more clear that you can see in the picture here. This is how the applicator looks like. It goes and rests over the cornea, and covers both the upper and lower lid. And once it does that, it will start giving heat and doing compressions simultaneously. Next, we have a handheld device called as Ilux. This is again from Alcon. So what will happen? It will catch your eyelid and it will take it up to 42 degrees centigrade. And from there for 30 seconds, it will keep producing heat. And once the heat is produced, you can manually push in that button and the mebum will start expressing out as shown in the figure. Next, we have something called as intense pulsed light. So this is a regulated pulse that is applied like that in the lower lid margin and at the medial canthus, because of which there is activation of the Mebomian glands and the lipid layer is formed again. Finally, we have something called as the neurostimulation, in which with help of a neural stimulation, it will indirectly stimulate the lacrimal glands to produce more tears into the eye. This is how it will look like. You can adjust the sensation you want to create in the nose. Once that is kept in the nose, it will slowly start to stimulate and you'll start to have tears that are produced into the eye through this mechanism. So finally, though there are a lot of techniques and treatments available for MGD, it is very important to remember in a lighter note that MGD is like your spouse. You presume to control it, but in reality, The control is only transient. Thank you for your time and attention.